auto admitted. Auto admitted. Nothing. So, starting the session, greetings from Bilmed Group of Institutions. So, first of all, I would like to request you to join with audio. And if you are already, if you have joined with audio, you will be able to listen, hear to me. And if you are able to hear my voice, then you have already joined with audio. So, we are starting the session. I would like to highlight there. First of all, I would like to highlight that this is not a course, whatever we are conducting right now, but is a question and answer session for our ongoing candidates who are registered with us for different server-based courses. So right now, this session is purely a question and answer session for our registered candidates who are undergoing different the courses on our server, and these are the questions which are in the list over here, which we'll be taking today. And we have got these questions from our candidates. I'm displaying it for your info. First question from Dr. Om Prakash is that how to differentiate different types of cysts. Then next question from Dr. Masum Shah is that how to differentiate minimal RPOCs from blood clots. So Dr. Shah wants to know how to differentiate an RPOCs from a blood clot post TMC. And Dr. Roshan's question is that how to use the knobs, for example, the settings, where to go first, what to press first, and how to change the transabdominal and TVS, etc. Now, Dr. Preeti is posting what is the concept of the pulse repetitive frequency. That is the first question. Second is that TVS screen orientation, localization of the ovaries. And Dr. Thomas is posting a question in a twin transfusion syndrome. If I am having a monochorionic, monoamniotic twin, how to diagnose it if there is a stuck fetus, and how to make out whether I am dealing with an oligo or hydroamniosis in case of a monochorionic, monoamniotic twin. And the next question from same Dr. Thomas is that how to differentiate a solitary cyst from RPD, that is the renal pelvic diameter. Third question, how to differentiate, how to diagnose a tentorial elevation of brain. And the last question is that when compared to ectopic pregnancy, what is the status of rise in beta HCG levels in a blighted ovum? So I have displayed all the questions what we have got, which we have got through our portal from our registered candidates. Anna, over to main screen. Okay. Now, first of all, first question, I am having a list of these questions also for my reference and your info here. If Dr. Om Prakash is online, please raise your hand, not this physical hand, but there is an option to raise the hand digitally. I mean, there are three dots over there, and there is the raise hand option. If Dr. Om Prakash is there, please raise your hand quickly. So the question from Dr. Om Prakash is that how to differentiate different types of cysts. So he is probably asking for the different types of ovarian cysts. So is Dr. Om Prakash there? And if Dr. Om Prakash is not there, anybody who has completed gynae ultrasound and wants to have interaction on this question can raise the hand so that we can unmute the microphone, but there should be no background noise from her or his side. So I'm waiting for the raise hand options so that we can connect with that person and take it in an interactive way. So Anna, keep an eye on the raised hands if they are any. Now, the question is that what are the different types of cysts and how to differentiate the different types of cysts? I would first of all request you to anybody who is posing the question to complete or at least touch the topic before posing a question, because this is actually a topic in itself which is detailedly covered in our gynae ultrasound. So I will take it in a answer way. I will sum it up. We are having different types of cysts in ovary. For example, a simple cyst. Then we are having a hemorrhagic cyst. Then we have to differentiate it from a corpus luteal cyst. Then why not a dermoid? And why not an endometrioma? You can pen it down. Why not an endometrioma? And lastly, we may have a complex ovarian cyst. The point is that I have to keep the findings of each and every cyst in my mind. Then I can differentiate the corpus luteum from a dermoid or dermoid from an endometrioma. Now, let's take two differentiations, a dermoid from an endometrioma. A dermoid, these things are in detail on our server. Please complete the class first before posing the question. If you have completed the topic, I bet that this question will never arise. So anyhow, I will sum up how to differentiate a dermoid from an endometrioma. In endometrioma, the size first. Size will vary. Now, you may think why. Those who have completed the gynae ultrasound will understand me. Those who have not even touched the gynae ultrasound will not understand why the endometrioma size will increase. So for now, the endometrioma size will increase or decrease. It means that it will vary in size overnight. When I say overnight, I mean maybe after 10 days, after 15 days, it will show me the next measurement. It means that the measurements will vary. So will be the echogenicity as well. Now, when I say echogenicity will be almost static in case of a dermoid, but in endometrioma, sometimes I'm seeing a high level of echogenicity, and on rescan, I may see a low level of echogenicity. So the moral is that the echogenicity and the measurements will vary, will change overnight in case of endometrioma. Now, a color Doppler will differentiate me in a way that dermoids are avascular. Please note it down. That dermoids are avascular, whereas the endometrium is the live tissue over there. It can show me sometimes the color flow. Now, the pain, clinically, you have to also correlate. Now, the pain. When I say pain, pain will be dull and persistent in case of a dermoid, but it will be cyclic in case of endometrioma. So this way you can differentiate. Now, if I am having a endometrioma, there are chances that I may have some adenomyotic patch in the uterus as well. So if I am having an adenomyotic patch in the uterus, it is going in favor of endometrioma, not in favor of dermoid. So bilateral. If I am having bilateral cystic lesion, that goes in favor of endometrioma, but if I am having unilateral, that goes in favor of dermoid. So this way you can differentiate the dermoid from an endometrioma. Now, a hemorrhagic cyst. When I see some internal echoes in the cyst, which was previously a clear cyst, anechoic cyst, I will putting a color over there. What for? Not to see the vascularity, but to confirm that there is no vascularity in that area where I am suspecting an hemorrhage, because hemorrhage is a dead blood, and dead blood will never be picked by the Doppler. So, but in case I am having some flow in that, that solid area inside the cyst where I am suspecting it to, when I am suspecting it to be a hemorrhagic cyst, it will never be a hemorrhagic cyst, but it can be a complex cyst. Then I have to differentiate it from a complex cyst, maybe a CA over there. So now for the complex cyst, to differentiate it whether this is the benign or malignant, there are check points. So there are actually 10 checkpoints that is in detail on our server. Please go to the server to pen it down and to understand the 10 checklist to make a probability of whether it is benign, malignant, or benign case or a malignant case. So this way you can differentiate different types of cysts. At last, again requesting you to complete the gynae ops, not ops, the gynae ultrasound, which is there on our server before posing these questions, because this is actually a topic in itself which will take you about 2 to 4 hours. So I completed the first question from Dr. Om Prakash. Now the next question from Dr. Masoom Shah is that how to differentiate an RPOC from a blood clot post DNC. Now, very simple. If there is a small area in the endometrium post DNC, you have to see whether it is a blood clot over there, or I am dealing with a RPOC. Right now, I will not be drawing, I will not be showing pictures, because that is already on our server, that is there. I am having a dedicated class, how to differentiate an RPOC from a blood clot. I guess that Dr. Shah has not completed, not even touched that topic and posing the question like this. So now see, the grayscale will not give you a clear-cut idea whether I am dealing with an RPOC or a blood clot. Color, hair color is helpful. When I say RPOCs, these are retained product of conception. Now, the retained product of conception are they're intact. There is a connection between that RPOC and the maternal blood. It means that there has to be some connection with the uterus. But when I say connection, I mean that that connection has to be the vascular connection. Now, vascular connection will be picked by the color Doppler. On putting a color Doppler, I will see that that hyperechoic or mixed ecotexture area is taking color. And if it is showing the flow, it cannot be just a blood clot. And if it is not showing the flow, that is going in favor of a blood clot. Now, here, make a red note that when I say Doppler is picking it, you have to do a lot of adjustment with your machine. You have to keep your PRF educate, because then if I am dealing with an RPOC, their flow, there will be a slow flow. For slow flow, I have to adjust the PRF. If I will not adjust the PRF, PRF is pulse repetitive frequency. There is a knob in your machine by PRF only. If you will not adjust that PRF, the slow flow will not be picked. And you will be unnecessary thinking on lines of the non-vascular area, because you have not adjusted your PRF. So the moral of the discussion, or the sum up of the question, is that RPOCs will take color, whereas the blood clots will not be taking color. But here the note is that adjust your pulse repetitive frequency to pick that slow flow in case of RPOC. Okay, now Dr. Roshan. Roshan is sending me a very funny question. Why funny? I will tell you why funny. The question is like this: how to use all knobs, for example, for setting where to go first, and what to press for all measurements. Dr. Roshan, if you are online, please come forward by raising the hand. Please raise your hand. Anna, keep an eye. Now, Dr. Roshan, you there? Not the physical hand. There is a button in your the more option. You have to raise the hand digitally. Digitally. There are three in more option. The three dots are there. On clicking onto the three dots, you will see a raise hand option. And when you click on the raise hand option, a pop-up will come in your software and we will unmute you. So, keep an eye. Now, see, we have given you a dedicated class of all the knobs, physics and machine settings, the knobology. It is itself a course. It is itself a sub course, I will say, not a course. Before starting any gynae ultrasound or ops, abdominal, we always start from the knobology. Now, why from to start this question? Because this is itself a topic. First of all, the different knobs over there, the different knobs. First of all, preset. Go with appropriate preset. Now, you may be thinking, why? The answer is in class. Go to the class. So I will give you a sketch of what to see when. First, the preset. Others can make a a sketch in their notebooks. First, the preset, and then the frequency. Then the frequency. Set the appropriate frequency. Keep in mind whether you need penetration or you need only resolution. I mean, if you don't need penetration, then you can keep your frequency high, because with a high frequency, the resolution will be more, but that will be at an expense of penetration. So judge yourself whether you need penetration or resolution. That is what I told you. You have to set with a frequency depending on your need. Third, if not the fourth, is the depth. Depth. Choose an appropriate depth. What I mean by the appropriate depth, if your area of interest is, am I not audible? Anna? Am I not audible? Now, the depth means that if your target is at 100, for example, is at 100, now there is a scale. That is what I am saying. You're telling you time and again, complete the topic first, then pose the question. Now, there is a scale. If on that scale, you can see that your target is at 100, for example, and you are keeping your depth as 200 or a 300, the beneath area, I mean, beyond 10, beyond 100 will be waste for you. But what if I will keep it at maybe 102 or 103, so that I am not more penetrating deep in the body? What will be happening with the machine is that my frame rate will be increasing. So the point here is not actually the depth, by adjusting the depth. The point here is to the improvement in the frame rate. So if I go more deep, if I keep depth more, it will be dramatically telling on the frame rate. That is why we need to adjust the depth. Keep it as minimum as possible, because a low depth will be having a high frame rate. So that was the fourth point. Then the gain. Your gain has to be not towards the brighter side, but towards the blackish side. Then the TGC. Your TGCs are nothing but the gain of an appropriate level on the screen. You can see where you need more gain or low gain, I mean the monitor. So adjust the TGC. Then the focal zones. There are multiple focal zones in your machine. So these focal zones should not be, in multiple, but preferably keep it only single. I mean, with a one focal zone, your again frame rate will be more. And if you go with the multifocal zones, your frame rate will drop down, and at the end, you will not be seeing a good picture. Then the focal position. The focal position has to be near the target. Zoom is the last option. Don't start with zoom and with zoom. And last but not the least, the color. The color will not improve the grayscale image, but it will dramatically drop the resolution of the grayscale, because the frame rate will drop with a color box over there. So don't expect that your grayscale image will improve with the color Doppler, but it will actually degrade the color, the grayscale image. So before putting a color, make sure that you have done with your grayscale image. So that was the sequence. Now, which knob to use when? What are the functions of that knob? For that, you have to complete the knobology class, which is there in detail on our server. That was question from Dr. Kirti, not Kirti, Dr. Roshan. Now, Dr. Kirti's question is that, what is the concept of the pulse repetitive frequency? Now, the pulse repetitive frequency, try to understand. The pulse repetitive frequency means that first the machine is sending you the the pulse in the body. Okay. Now imagine that the machine has sent out the pulse in body. Now it is sending the pulse and waiting for echoes. Try to understand. It is waiting for echoes, and when it receives back echoes, then only it will send the next pulse. Now there is a gap in between, a time gap in between the preceding pulse and whatever I am sending it right now. Now, imagine how much the time will be for listening. Will it be more than the sending beam by machine or less than? It has to be more than. Now, about 99% of the total time, the machine is listening to the echoes. Now, only 1% of the time, machine is actually sending the wave, I mean the pulse. Now, this is the duty factor. Now, when I say duty factor is 1 in your machine, 1. So when I say duty factor means the total percentage of the time taken by the machine or spending by the machine to send the wave, the pulse in the body. 99% it is listening to. Clear? Now that was the duty factor. Now, what is PRF, pulse repetitive frequency? The pulse repetitive frequency, as the term itself means, that how frequently I am repeating the pulse. How frequently I am repeating the pulse. There is a knob in your machine for that increase or decrease of this PRF. Now, when actually you say the PRF, you are saying the repetitive frequency of the pulse in the body. If you increase it, what will happen to the duty factor? Now, this is the question which I am putting to you. What will happen to your duty factor if you are increasing the pulse repetitive frequency? Now, if you are decreasing the pulse repetitive frequency, what will happen to the duty factor? What will happen to that listening period? Please give a thought. That is why with your PRF, when you are adjusting it, you are able to pick the slow flow, what I told you in the RPOCs. So that was the pulse repetitive frequency. Now, TVS screen orientation, next question from Dr. Kirti. TVS screen orientation, now see here, the screen orientation will not be like I am having in the TAS. You have to see where you are putting the probe and where the marker is. This is in detail in our gynecological ultrasound. How to take the volume of the ovary. Like I have taken this question multiple times. I don't know why people are not going to that volume measurement. In our physics and mathematics, we are having a volume measurement, how to take volume. So in volume, I have to take 3 measurements, and 3 measurements are possible in 2 sections. One in transverse section, one in longitudinal, one transverse and one longitudinal section. In longitudinal section, I will be taking the superior to inferior, that is the length. And in transverse section, I will be taking anterior, posterior, and right to left. Summing all will give me the actual volume. So don't take three measurements of the volume in one section. When I say section, I mean transverse or longitudinal. You have to actually take the three measurements in two sections. I mean transverse plus longitudinal section. Now, the last set of question is from Dr. Thomas. Dr. Thomas is telling us, what if I am having a, try to understand, what if I am having a monochorionic, monoamniotic twin? Now, when I say monochorionic, monoamniotic twins, I mean that I don't have any intervening membrane. If I don't have any intervening membrane, neither I am having an intervening amnion nor the chorion. Now, understand the question. If now I'm reading the question, if TTS occurs in monochorionic, monoamniotic twin, how to diagnose its stuck fetus? Stuck fetus. Those who have completed the are understanding me what the stuck fetus actually is. Now, stuck fetus is possible only and only if I am having the membrane which is pasting, which is getting pasted onto the fetus. Here I don't have any membrane, so no question of having the stuck fetus in case of a monochorionic monoamniotic twin. That is one. So I cannot have a stuck fetus in case if I am having a monochorionic monoamniotic fetus, because in stuck fetus I should have a pasted membrane onto the fetus so that I will be having it getting it pasted onto the walls. Now, how to diagnose an oligoamniosis or a hydroamniosis is not possible if I am having a monochorionic monoamniotic, because I cannot say whether this fluid is of A or B. So I cannot say whether A is having polyhydramnios or A is having the oligohydramnios in case of a monochorionic monoamniotic. But try to understand, there are many things besides this stuck twin or the oligoamniosis which will tell me I am dealing with the TTS. When I say TTS, twin-twin transfusion syndrome, I am having first of all a discrepancy in size. If I am having a discrepancy in size, then I am having a color Doppler. If the ratio is more than 20%, difference in the ratio is more than 20%, then I can say that Doppler is also telling me I am dealing with the TTS. Now, a simple bladder, urinary bladder, I mean, if I am having a discrepancy in the bladder also, it means that the one is not having a full bladder, is a donor, and another is having a full bladder, that is the recipient. So other grayscale images are giving me an idea of whether I am dealing with a TTS or not. But the point is that I will not be having a stuck fetus, and I cannot comment on the oligohydramnios in case of a monochorionic monoamniotic twin-twin transfusion syndrome. Next question from same Dr. Thomas is that how to differentiate a solitary cyst kidney from RPD. Probably RPD, he means here renal pelvic diameter. Renal pelvic diameter will look like renal pelvic diameter only. It is the pelvic diameter. Why you will confuse a pelvis with a cyst or a cyst with a pelvis? So this is very much understood. Now, the third question is that how to diagnose a tentorial elevation in brain. Now, when I say tentorial elevation in brain, you have to first of all take the coronal section, and you have to visually see tens of tentoriums normally. Now, if now your visual impression is giving you that the normal tentoriums are here. Now, if the tentorial elevation is there, it has to be with some pressure beneath, and some pressure beneath onto the tentorium will be if the fourth ventricle is dilated. So if your fourth ventricle in that fetus is dilated, that is actually making this tentorial to elevate. So the point here is that you have to first see many normal tentorians in the coronal section, and in case you are having your fetus, I mean whatever you are scanning is having a fourth ventricular dilation, that is putting a pressure onto the tentorium, making it to elevate. Now, the last question of the session from Dr. Thomas again is that how to compare an ectopic pregnancy, when compared to ectopic pregnancy, what is the status of a rise in beta HCG titer in blighted ovum? Now, in blighted ovum, I can have a normal increase in beta HCG up to maybe a 6 to 8 weeks. But when I say this ectopic pregnancy, in ectopic pregnancy, I will not be having such an increase as I am having in a blighted ova. Now, if I am having a blighted ova and I am very much sure that this is blighted ova, why I will confuse it with a pseudogestational sac? Because I am having maybe a good decidual reactions over there, and the sac is intrauterine. Then you have to put all the things, whatever is taught to you in the ectopic pregnancy. In ectopic pregnancy, lastly, we are having a sketch over there. I know that the question, why question is arising? The question is arising because that blighted ova is not showing me any fetal pole. So the pseudogestational sac, actually, that doctor wants to have a comparison of a pseudogestational sac with a blighted ova. Pseudogestational sac will be in center or eccentric, usually eccentric. Pseudogestational sac will be in center. Yes, centric. Pseudogestational sac will be pointing towards the tapering towards the cervix, that is the beak side. So you have to put all your neurons in action. But to be precise with your answer, that question, the answer will be yes, there will be a rise of the beta HCG, which can be more than the ectopic pregnancy in case of a blighted ova. So thank you very much. God bless all of you. No. If you will be having any more questions, we'll be entertaining, of course, your questions, but request. First of all, please at least complete the 50% of the topic. Try to understand my point. At least 50%. I am not saying you complete the topic, then pose the question. At least 50%. Because whatever questions can arise, maybe it will be covered in your session over there, in your classes over there. So preferably complete the 50-60% of the topic. Then whatever questions you are there, you are more than welcome to put on our portal, and we are taking these types of interactive sessions on a regular basis. When I say regular basis, it is depending on the demand, how much is over there. You have to post your questions when we announce the interactive sessions on our helpline number. You are added in our WhatsApp groups. So thank you very much. God bless all of you.